All right, hello and welcome to the Gippsland Regional Integrated Cancer Service Annual Forum for 23-24. For anyone that doesn't know who I am, my name is Stuart Harper. I'm the Program Manager for the Gippsland Regional Integrated Cancer Service. And I'd like to officially start today by acknowledging the traditional owners of the land on which we meet today, which is the Briarkalung clan of the Gunai Kurnai Nation. And I pay my respects to elders past, present, emerging, and I extend that to any Aboriginal or Torres Strait Islanders that may be joining us today, either in person or online. Just before we start with the introductions of the people who are actually talking to you today, I'd just like to acknowledge the team from GRICS and the work that has been done over the last 12 months to get us here today. So up on your screen is the whole team. I won't call them out individual by individual, but what I'd really like to focus on is just some of the projects that we've delivered over the last 12 months. So I'll start with the Regional Cancer Plan. The Regional Cancer Plan was developed back in 2022 and endorsed by the Department of Health. And we've been slowly implementing the recommendations from that Regional Cancer Plan. So certainly here in Gippsland, there's been a focus on shared clinical governance in the cancer sector and basically having a project to push that along. So I'd like to acknowledge that. As well as improving palliative care referrals for our upper gastrointestinal patients. So another significant project that we've been developing over the last 12 months is trying to improve that early access to palliative care. There's been some significant work in the melanoma and skin cancer space. So at the moment, about 70% of patients from Gippsland are going outside of Gippsland to seek treatment and care. So we have a number of projects happening locally, trying to keep those patients within Gippsland. Also, under the Exercise and Cancer project, that's been a significant piece of work that's been going on for a couple of years now. And we've continued to collaborate with Latrobe Community Health Service and Latrobe City Council to deliver an exercise physiology-based program for our cancer patients. Likewise, we're just commencing an Aboriginal engagement project. So that's really looking at how we can better deliver cancer services for our Aboriginal patients locally here in Gippsland. As well as some significant advances that we've made in the data space. So GRICS now has access to a significant amount of data that we would like to support our health services across Gippsland to access that information and use that to implement changes within their own health services. So that's just a brief update. And likewise, if you want any further information about GRICS, we've got a brand new website. So head there and you can have a look and see what we do. But now I'd like to welcome Dr. Mahesh Idawila, the Clinical Director for the Gippsland Regional Integrated Cancer Service, up to the lectern as your chair for the evening.
Thank you very much, Stuart, and thank you very much for everyone for joining us in here and online. And it's been a eventful year, and we got a few great presentations. Just highlighting some of the important work that's been happening. First up is Dr. Ellie Ristevsky. Ellie did her PhD in public health and senior lecturer at the Rural Health Monash University based in Warragul. She's been really pioneering some of the survivorship work in the regional areas, and we worked together to develop the Gippsland Cancer Survivorship Program 2016 and really led some important work, really collaborating with the CALD communities and ATSI communities locally to try and get them involved in cancer care and survivorship. So it's really leading some important work in this area and as well as palliative care and patient experience, collaborating extensively with people in Gippsland and other regional areas as well. So it's been a pleasure to have her in the team, and we look forward to hearing what she's been doing with the project.
I'm not Ali. My name starts with Sinead, and thank you to GRICS for having us. And sorry, Mahesh, I didn't mean to mess things up for you. I'm just trying to work out. We were fortunate enough to receive funding from GRICS for a service improvement project down in Warragul, and the project we called It's Just a Tablet. And we're doing this project has been done in partnership with Monash University. So it's based down at Warragul, funded by GRICS, but we've had a very strong partnership running with Monash University because we knew how important this work was and what an enormous gap in care there was, not just locally, but we'll go into that. So that partnership with Monash University meant that whatever we sort of knew on the floor was happening, we could actually get evidence and support in terms of the outcomes of what we were doing to ensure sustainability of anything that we found out was valued. And I can't say research is the thing that excites me the most, but I'm learning. It's a moving space, and thank you to Ali and Michael for their tolerance of me. I truly appreciate it. So why are we doing it? Cancer is cancer. It doesn't matter what sort of treatment, it doesn't matter who you are, it doesn't matter what language you speak, it doesn't matter anything. Cancer is cancer, and once you hear that word, your life changes forever, and so does that of your families and your friends and your community. So that's why this is important. The availability of oral anti-cancer medications is increasing, and Michael will speak more to that, so I won't go into that. Local and international guidelines. We have literally reams of paper. We have the cancer plan that's just been released that talks about it. We have the COSA guidelines. There used to be a specific one for oral treatments. It's now included in a couple of pages, so it's become more important. We have our quality safety guidelines. We also have our Safer Care Victoria guidelines. There's international guidelines. There's New South Wales health guidelines. There are so many guidelines, but they're all just that. They're guidelines. We don't actually have to do anything, except we need to care for our patients. So that's why we need to do this work. So there's a lack of consistency, and that's not just in our local region. People think that the regions, don't do as well as the metro areas. Metro areas are just as bad, sometimes actually worse than what we're doing. We have a degree of traceability of our patients. We can keep track of them. There's not a whole lot of difference between the metro and the rural, and there's not a whole lot of difference between international, what's happening over there either. Historically, locally, patients are prescribed their medications. They're not necessarily linked with cancer care nurses. In some services they are, but not all. The education is provided by their doctors. They're given their Evercue sheets, and then their dispensing pharmacist will do a degree of education as well. In some services, the pharmacists very kindly monitor the patients. They don't do supportive care, but they do the best that they can with the resources they've given. But in actual fact, the Cancer Council has given us the optimal care pathways that started in Victoria and now are Australia-wide. And throughout those pathways, our aim is to provide consistent patient-centred care, and the optimal treatment and care includes our supportive care. It needs to be safe and it needs to be equitable, and that's why we're doing this. So that's why we're looking at the unmet needs: physical, emotional, spiritual, practical, and social. And this is their new sort of what do I call it, image that they've used in the cancer plan over the normal optimal care pathways have been something that's just been tracked. Supportive care has been a little line down the side of them. This is a little bit more detailed in the fact that supportive care should encircle the patient and everything about them. So I talked about the guidelines. There is lots of evidence in literature, but that's Michael and Ellie's expertise, so I'm leaving that there. We talked with the oncologists, with our colleagues, with pharmacists, with drug reps, and that's where we've gotten to where we are now in our model. We've had a huge engagement with consumers, and not only the GRICS consumer group, but actually consumers just in the space that we coincidentally run into. They have been some of our most useful and guided absolutely what we're doing at the moment. We've also engaged with health literacy, and we've scoped other regional, metropolitan and international services. Prescribing data is really difficult to find, and that's where we get to next. It's difficult to accurately find, and that's not just because of Gippsland. The way these tablets are prescribed can be really different, and there's really not traceability except for dispensing data. So Michael's going to talk to you now, and I'd like to, well, Mahesh can do the introduction. I don't want to do you out of a job.
Sorry about that. So that was Sinead Hitchcock. Sinead is a registered nurse with 30 years experience in intensive care and oncology in Gippsland, and she's really been leading some very interesting projects in working as an in chemotherapy unit at Warrigal together with GRICS and the Warrigal team, and then she's leading this project with the Monash University. So you heard about the issues that she faced and all oncology units face, and as clinician, we do write prescriptions and give it to the patient and give them information, and then they come back few weeks later after taking it, and we assume that they've taken the right amount and right quantity and with the right spacing, I think, but that really can be a random thing sometimes, and so it's very important, and that these patients are properly educated and followed up and monitored. So that's the important part of this project. So I think then going back into the program, so next it will be Michael Leach. Michael is a rare entity in a way. It's a pharmacist and a statistician, and he did his PhD in pharmacoepidemiology, and he's a senior lecturer at University of Monash Rural Health in Bendigo, and he's been working on improving the quality of regional cancer services, especially in the Loddon Mallee region, and he worked as a data and quality specialist at the Loddon Mallee Integrated Cancer Services, as well as Cancer Australia, to lead the data-driven regional cancer care initiative. And he's obviously really passionate about using the data to improve the care of our patients, and obviously he's got valuable experience from a pharmacy point of view. So let's hear from Michael about really what's happening in the regions.
Michael's online with us, but he's actually pre-recorded his presentation. So I will start. It's called Trends in the Dispensing of Oral Anti-Cancer Medications Across Australia. Over the last 10 years, there was actually no data locally. So yeah, I'll let Michael talk about it, and hopefully I can start the video for you, Michael.
Hi everyone, I'm Michael Leach and I work at Monash Rural Health's Bendigo site, which is located on Dja Dja Wurrung country. I would like to acknowledge and extend my appreciation for the Dja Dja Wurrung people, the traditional owners of the land I'm speaking and recording from, and to pay respects to leaders and elders past, present and future. In this presentation, I'm sharing results from a collaborative study of trends in the dispensing of oral anti-cancer medications across Australia over 10 years. And a paper based on this work has been submitted to pharmacoepidemiology and drug safety. So in terms of background, oral anti-cancer medications, or OAMs, comprise about a quarter of all marketed anti-cancer medications. Like parenteral anti-cancer medications, OAMs are potentially life-saving yet high-risk treatments. The overarching advantage of OAMs over parenteral anti-cancer medications is ease of oral administration. Patients can self-administer OAMs in their own homes without needing to travel to cancer centres to receive parenteral treatment. However, like parenteral anti-cancer medications, OAMs are classified as high risk because they can lead to potentially life-threatening adverse events, and non-adherence can be particularly problematic in people prescribed OAMs. These issues may be partly due to the fact that those taking OAMs typically have less contact with oncology staff and thus less monitoring, education and support than those on parenteral agents. OAM errors and serious adverse events have been reported in Australia and internationally. Potential drug interactions involving OAMs are quite common, up to 89%. And OAM initiation is known to trigger unplanned ED visits and hospitalizations in around 13% and 11% of patients, respectively. Few known studies have examined trends in population-level dispensing of OAMs. Upward trends in OAM dispensing rates have been found in some countries, such as nationwide in the Netherlands over 9 years. All of the overseas studies in this area have investigated trends in OAM dispensing over periods of at least 8 years. In Australia, however, trends in OAM dispensing have only been investigated over 4 years. This Australian study found an upward trend in the rate of non-hormonal OAM dispensing per 100,000 people in a 10% random sample of Australians. No known studies have examined long-term trends in OAM dispensing at national or subnational population levels in Australia. So, we aim to examine trends in OAM dispensing at the national population level in Australia, as well as in Australian states and territories, over the 10-year period 2014 to 2023. Now the method. We undertook an ecological study involving secondary analysis of aggregate population-level data. Australia-wide dispensing data was sourced for January 2014 to December 2023. Dispensing counts for OAM products subsidised under the PBS or RPBS, broken down by state or territory of dispensing and year of claim processing, were sourced from Services Australia's Pharmaceutical Benefits Schedule item reports. Equivalent dispensing counts for the broad group of any anti-cancer medications were sourced from Services Australia's Pharmaceutical Benefits Schedule group reports. Additionally, we sourced data on Australia's estimated resident population by residential state or territory and year from the Australian Bureau of Statistics. OAMs were defined as PBS medication products corresponding to ATC Level 2 codes for anti-neoplastic agents, endocrine therapy, or immunosuppressants, except those unavailable in an oral dosage form, not indicated for cancer, and not PBS or RPBS subsidized. Cyclophosphamide, mercaptopurine, and methotrexate were excluded, as they're mostly used to treat autoimmune diseases, and indication details weren't available in our data sources. Any anti-cancer medications were defined in a similar way to OAMs, but at the whole L group level rather than lower level groups, and without restriction to only oral products. Data on OAM dispensing and estimated resident population were used to calculate OAM dispensing rates per 100,000 population. Rates were calculated overall by year, as well as by medication class in each year, and by the state or territory of the pharmacy in each year. Where valid, Mann-Kendall trend tests were used to test the trends in dispensing rates over time, with p-values less than 0.05 denoting statistical significance. We also assessed the sensitivity of results to using an alternative cancer-specific dispensing denominator, the count of any anti-cancer medication dispensing, rather than the estimated resident population. Data analysis and visualization were undertaken in Excel and Stata, and ethics approval was obtained from the Monash Uni HREC. Now on to the results and discussion. From 2014 to 2023, hormonal OAM dispensing decreased non-linearly and non-monotonically from 2,659 to 2,225 dispensing episodes per 100,000 population, a percentage change of minus 16%, while non-hormonal OAM dispensing increased near-linearly and monotonically from 816 to 1,705 dispensing episodes per 100,000 population, a percentage change of plus 109%. Across the whole 10-year period, there was a statistically significant upward trend in the rate of non-hormonal OAM dispensing Australia-wide. This is consistent with upward trends observed in other countries, such as the Netherlands. It likely reflects rising availability of, demand for, and access to non-hormonal OAMs. Demand for anti-cancer medications is expected to increase over time in countries with aging populations, such as Australia, because cancers are primarily diseases of the aged, and cancer survivorship is increasing. Med-oncs and hematologists may be increasingly prescribing non-hormonal OAMs due to ever-rising availability, and due to perceiving that the benefits of oral administration, such as patient preference for greater convenience and autonomy, outweigh the corresponding challenges, such as non-adherence and adverse events. And the significant upward trend in the non-hormonal OAM dispensing rate on the previous slide coincided with a significant upward trend in the number of individual non-hormonal OAMs dispensed, a figure which approximates the number of OAMs marketed in Australia. When we look at data broken down by medication class, we see that the significant upward trend in non-hormonal OAM dispensing is largely driven by a significant upward trend in dispensing of protein kinase inhibitors, or PKIs. This finding is consistent with that of a past Portuguese study. PKIs such as everolimus, imatinib, and dasatinib are important 21st century medications that target different members of the protein kinase family. There was a statistically significant upward trend in the non-hormonal OAM dispensing rate for each of Australia's 8 states and territories, and these dispensing rates varied by state and territory. Vic was always at or towards the middle. SA had among the highest OAM dispensing rates, as well as the greatest percentage increase in rates from 2014 to 2023, plus 141%. Non-hormonal OAM dispensing rates were highest in Tas during most years of the study period. This is noteworthy because, unlike all Australian states or territories except NT, Tas lacks a metropolitan centre, and OAM dispensing rates for NT were markedly lower than for any other state or territory. These results may partly reflect the fact that SA and Tas have relatively old populations, and NT has a relatively young population. Prescriber patient preferences and accessibility considerations may also explain the state and territory level variation in dispensing rates. This warrants future investigation. Now on to the results of the sensitivity analysis, in which the dispensing count for any oral or parenteral anti-cancer medication was used as the denominator instead of the estimated resident population. The most salient point here is that the upward trend in non-hormonal OAM dispensing remains statistically significant in the sensitivity analysis. Regarding limitations, claim processing year may differ from supply year, while the state or territory of the dispensing pharmacy may differ from the patient's residential state or territory. OAM dispensing rates were not age standardized because our data sources lacked age-specific dispensing data, although we did partially address this limitation in the sensitivity analysis with a cancer-specific denominator. And as only PBS or RPBS subsidized dispensing was captured, OAMs provided off-label or through compassionate access were excluded from our study. To conclude, Australia's non-hormonal OAM dispensing rates increased from 2014 to 2023, mostly for protein kinase inhibitors and in SA, with interesting findings for non-metropolitan Australia. There is rising availability of, prescriber patient demand for, and access to these potentially life-saving yet high-risk medications, suggesting growing scope to pilot and expand OAM adherence and safety initiatives across Australia. Such initiatives may include nurse and/or pharmacist-led clinics. I'd like to acknowledge that this study was funded by the Gippsland Regional Integrated Cancer Service and Monash Rural Health. Thank you for your attention.
Thanks, Michael. And Michael's online and available for any questions that you'd like to have. There's a lot in that. So Ali's going to present in a minute, but the aim of our oral anti-cancer care clinic is to develop and pilot test a supportive care screening, education and monitoring pathway for rural cancer patients that at the minute just reside in West Gippsland who are prescribed oral anti-cancer medications. The regimes have multiple risk points, as Michael has said, and they leave the consumer vulnerable for toxicities, distress, adverse events and suboptimal experiences, including not only their diagnosis, but their variable dosing, multiple agents, rest periods, everything else that includes these challenging regimes. And then we can talk about adherence, because lots of the data talks about adherence, but what is it and why is it so important? So Ali's already been introduced, but now I'll pass the baton to Ali and let her present.
Thanks, everybody. And thank you to GRICS for inviting us to talk about this project that we're so passionate about too. So I would also like to acknowledge the traditional owners and custodians of the lands of which we're all meeting on today, and from people on Zoom, and pay my respects to elders past and present. So my presentation today is really some preliminary data that we've been doing in terms of a scoping review. So I'll talk you through that. So I'm not sure if that's working correctly, but it seems like there's a Okay, yeah, that's fine. I'll just go with it. So, so the first slide is really about, I won't go over these points. So it was really, it's just an introduction to oral cancer medicines. There are lots of positives, as Sinead and Michael have already mentioned, and there are lots of negatives in terms of for the person taking the medicine. So there are pros and cons, as they say. So I guess to inform our project, we really wanted to start with, we did a scoping review, so a review of the literature. And so we really wanted to look at, well, what are patient, clinician and organisational barriers and enablers to looking at medication adherence and monitoring for people prescribed OAMs. So this will, I guess, inform what we're doing. All right. And so using the JBI method, what we were interested in looking at is people that are over the age of 18 could be diagnosed with any cancer, any professionals, any health services, and really it had to say they were prescribed OAMs, and we did exclude people exclusively on hormone and endocrine medicines and people on immunotherapies, not for cancer. And we were really looking at adherence, monitoring, barriers, facilitators. So we did exclude education-focused studies because there are actually quite a lot of systematic and literature reviews on educational interventions. So that's already been done, but not really a lot on, not collated evidence on adherence and monitoring. So that was our focus. So in terms of our search, so we searched 4 databases and we were looking for studies that were done really in this century, I guess you could say, so 2000 onwards, published in English, of course, and peer-reviewed. So in the exclusion category, we did exclude conferences, opinion pieces, things that were not peer-reviewed as well, study protocols, so things that didn't have any primary data that we could pull out of that. So our screening was all done in confidence, and as per the JBI process, is one person starts screening all of them, and you will see there's quite a lot to screen, and then 2 screeners complete the rest, and then exported into Excel and synthesized according to our questions. So, okay. So these are this is the result of the database search and the extraction. So 847 articles we identified. So after removing a lot of duplicates and through that screening process, we have 61 articles that we have included. And so they are preliminary results because as we've been trying to extract data, and I'll talk about this, is that some of the evidence is a little bit loose for what people are claiming has been an outcome, but we have included it because the scoping review is really mapping what people have done. So, yes. And a lot of conference presentations, so quite a lot. And it's interesting that there is a lot of those because so people are doing projects, presenting and talking about it, but not necessarily, it's not being moved into a research or a publication type of format. So, okay, so I'm going to talk about a lot about the studies and the participants that we found. So I'm not going to go into the barriers and the facilitators because there is quite a lot and we are still extracting that data. But I guess it's really important to know, what people have done, where's it been done and what's been happening. So I'll share that with you. So in terms of where a lot of this research has come from, you can see from this map, it's actually quite spread out across the world, but I'm not sure if I can use this pointer, but most of the studies coming from the United States, and then another bunch are coming from really Western European countries. And we can see in Australia, we've located only 3 studies. So, and most of these studies have been done, as you can see in this table, so hospital-based, comprehensive cancer centres. So a lot of the terminology is overlaps, and so depending on the country and the way the service is structured, little bit hard to tell where some of them have been done, but generally they're in hospitals or cancer institutes, and some around sort of oncology practices. But interestingly, no rural-based or led studies. So, okay, so in terms of when a lot of this research was done, so this is in terms of year of publication. We can see it's really starting to, around 2001, the research is starting, and then it's starting to kind of grow. And the 2024 bar will probably go higher, sorry, because we extracted these about a month ago, and sometimes it takes a while for publications to translate. So people are starting to publish more about these areas. And I also did a bit of a look at, well, the time frame for studies that have been done. And as you can see from this graph here, there's a lot that don't report when they actually did the study, but pretty much most groups had done the study within the same year or years 1 and 2. So there's not really a lot of longitudinal studies at this point. So the studies are quite new and relevant. So then I had tried to have a look at the study design. So what were people actually doing? And again, this was very tricky. And so I've got this pink box here. So a lot of the studies are observational studies. So while there was some RCTs and a mix of other things, quite a lot were observational studies. And then I put this dot here is that a lot of them, I actually could not work out what study design was. So whether it's not reported or the robustness of the research isn't as great, it's a bit hard to tell, but lots of people doing observational type studies. So that's quite interesting. So who's involved in a lot of this research? So as you would expect, 51 of the studies look cancer patients in them. And so if you have a look here, so there's about 45,000 people, but that figure is disproportionate because one study had 37,000 people, which was like a database, a big American database extraction from one of the pharmacy databases they've got there. So when we take that out, pretty much sample sizes are very small. They're like 7, like this one had 1,800, but again, they were really around, 20 people up to 50, maybe sort of 100. And in terms of the cancers that were represented, so again, interestingly, so a lot of the studies had various types of cancers. So a lot of studies are sometimes overrepresented with breast cancer patients, but these studies were, most of the cancer patients were breast, colorectal, and lung. And then there was a handful of studies that just looked at one tumor type as well. So a couple of studies with caregivers, and then a few studies with clinicians, and looking at these disciplines, medical oncologists, pharmacists, nurses, and one had a resident. And then one study was a big organizational study. So we also wanted to look at diversity within these studies that were done. So I did a little bit of extraction here and really, again, not a lot of diversity. So what we are knowing about people is people mostly living in Western type countries, probably with good socioeconomic status, probably can speak the language of the country. So there's not a lot of diversity. So gender is always binary, and that hasn't caught up, I guess, in the literature. Ethnicity and race get mixed up. So some people call one thing ethnicity, other people call it race. So this is something that really needs some consistency. And really only one study with First Nations people. And in that study, there was only two First Nations people in that. And again, 4 studies that looked at language. And while there wasn't any rural-led studies, there was 3 studies that had some rural participants. But again, got to dive a little bit deeper in this because it was inside metro, outside metro. So again, depending on the context of the country, it may not be, I guess, rural. So then we had a look at, well, how was adherence and monitoring looked at? So as you can see from these pink boxes here, most are patient experience studies, as you expect, quite a lot of that. Then there's a whole bunch of pharmacist-led studies that were looking at different types of interventions, clinics, processes and systems. So quite a lot of that, and also multidisciplinary teams as well. And so I just wanted to give you a quick snapshot of the Australian studies, just to see what's been published here. And again, what it's showing us is that, so if we look at in terms of publication, so they're still quite relatively new when these studies were done. But so one study done in Sydney, one at Peter Mac in Melbourne, and the other one was a survey of the Medical Oncology Group of Australia. So one of them was a pharmacy-led intervention. So they're really looking at evaluating that intervention and small sample size, so 29 patients in that one. And that study did actually ask people about language. The study at Peter Mac was qualitative, so I looked at patients' experience of OAMs. Again, 25 is actually quite large for a qualitative study. So, and then the last one is around attitudes and barriers, I guess, looking at medical oncologists. So 3 different studies that we can see there. So I guess to summarize all of that, so what I can take at this point is really there's no rule-based or led studies, which I think is a bit of a problem because I guess there's limited knowledge around what our workforce needs are, and I guess feasibility models as well. There's limited rural participants, again, limited knowledge of people's experience and also acceptability. And also the Australian studies are quite different. So I guess we need to know a bit more about health systems capacity as well. And as I said, like the observational studies are very weak evidence in what people are claiming has improved people's adherence. But the good thing out of that is the models of care are really showing there's lots of pharmacy and multidisciplinary models of care. So that, I guess, leads us, which Sinead has already introduced, is our study, which is looking at really trying to develop a model that's going to incorporate supportive care, education, monitoring and pathway. And we're focusing on Gippsland, and we're starting with a pilot and feasibility study because we want to try and get those processes right. We don't want to jump into a model that's going to fall down. So we want to start small and build that collaboratively. And I think I had a thank you slide somewhere, which has disappeared.
Thank you again.
I have you. Okay. So yeah, thank you. So I'd like to thank my collaborators, and I'd also like to thank GRICS for the opportunity for us to undertake this project as well. We're very grateful. Yeah, thank you.
Thanks, Ellie. I think I've got your job, Mahesh. Anyway, I'm going to just talk about what we're actually doing. And this is how we have branded our clinic, and it stands for Oral Anti-Cancer Care Clinic. And green is my favourite colour, so that's why we chose green, but we wanted to show that there is life with treatment, really. And the oak tree, also Holly did tell me, and Mahesh could probably pick me up there, the oak tree is actually, I'm sure there's a substance that comes from the oak tree that contributes to an oral treatment. But anyway, I wasn't that deep. I just loved it. So sorry, I'm just an absolute nurse to the bone. But anyway, and I still absolutely love my job. So how have we done this? Let me tell you, ethics is an absolute challenge. We've got ethics approval of this project, and it's incredibly challenging. So my advice to anyone taking on a project is find some friends that are really good at it, like I did, because I just could not have done it without them, because it's on a whole nother level. And they absolutely need the people on the floor to inform what we need from the ethics, but in terms of what ethics needs from us and for us for this to actually succeed, you really need to partner with friends with benefits. So the right benefits. Anyway, so the patients are identified by the medical oncologist. As part of this, we're not including haematology patients, and that's because not only because of the complexity of the patients, but also in Warragul, our haematologists are private. So that, added an extra level of complexity. So they are not participating. The pilot is introduced by the medical oncologist, and the patient's given a patient information form and a brochure that we have. The patient consents to being contacted by the nurse within 7 days of that point. At that point, we've got a referral form the medical oncologist sends on to me with just the general details of their disease and contact details. And then they're contacted via phone to give verbal consent. They either agree or they decline, and that's documented. The declines, that's where it stays. But they're always given the option to ring back or hop back in. We are keeping it at the moment very fluid. People are hopping in and having a try, and if they don't like it, there is absolutely no requirement for them to stay on board, and it does not change their care. At that point, if they agree to be participants, they're sent a welcome letter. We confirm consent, and we organise a first appointment. And at that first appointment, we then do a written consent. I answer any questions that I'm able to, and clinic proceeds. So we have just kept, this is our current referral form that's been manipulated. We didn't want to reinvent the wheel. So essentially, it is very similar to the referral process that happens for, all other cancer patients now for treatment in a unit. We've added some bits and pieces, and that's also in a trial format. So we'll see how that goes. And that's adequate for funding so that we can use that as our referral in terms of ABF. So we've partnered with them as well to know what we're up to. This is our beautiful brochure that the patients are given. And I'll just skip over these because there's a lot in it. But they are given a brochure. It's very open. It's gone through health literacy and everything else. And the GRICS consumers and other consumers as well, to make sure we weren't going to do a brochure, but the consumer says, what do we have then? So that was the patient information form was a lot, but necessary for ethics, and the brochure is what the consumers want. So we've done both, and we'll see how it goes. We do have a clinic process that's very set out purposefully in what we're doing so that we can maintain continuity. And so it's sustainable in terms of, at the moment, it's me, but we want it to be sustainable for other staff to be able to manage this and other units. So that's why we have set a clear defined process in place that's as a pilot set for change. We're using Genie documentation as we do across the region, but Genie is used by the med-oncs, not necessarily in the chemo unit, but for the clinic, we are going to continue using Genie. And in that, I've actually set up a checklist. I'm not sure if people are familiar with using them or not, but it's an OAK clinic checklist. And that's also so that we've got continuity in assessment of the patients. So it's literally just a very easy concept. It's just a checkbox that you go through. It's all set up so that it aligns with EverQ patient assessments and gradings and everything else using the UConn's grading score. So it's all set out in that. There are text boxes as well to add comments. So it's not set solid that you can say, I don't know. In the text box, you can absolutely write, I don't know. So it's reasonably long, but it won't all be filled out for every visit. And using the UConn's tool as we do. This is the beautiful printout that the checklist gives. So I print that out, I give a copy to the patient, send a copy to the GP along with the letter. And at the bottom, it's got what we discussed and anything they've got to do moving on, as well as their next appointments and what we've got to do before those appointments. So it's very clear, concise. The feedback so far has been very good, but we'll see how we go. The research component, Ali has sort of talked about what we're doing. There is a lot of data collection, and I do worry that it's too much for me. No, too much for the patients. I think there is a lot, but we're just going to see how we go. That's why it is a pilot. We are looking at satisfaction with the pharmacist because the patients will have interaction with the pharmacist, and that's with our local pharmacist in Warragul. We're looking at quality of life because that is the most important thing. We're also looking at communication in terms of communication from the nurse and their oncologist. And we're looking at the supportive care tool, but also the K10, which, you know, lots of us have dropped off a little bit, but depending on their screening tool score, we'll then escalate to a K10. And if that scores, then we'll do the referrals appropriately. We're using de-identified data for the relationship with Monash, and we're using REDCap. Another learning curve. Yep. Anyway, we're getting there. I just wanted to finish off on a really positive thing. I'm really conscious of time, but fortunately, and I'd encourage any of you, if you have that opportunity, you know, sometimes we get really super busy with life, and I decided this year that it was time to live life as well myself. So I was really fortunate to go to Ireland. Obviously, Sinead, I'm not from any other country. My dad is Irish. And I was fortunate to go to Ireland for a month with him. And we were doing such great work in the project. I thought, I'm just going to see what they do over there. And it was fascinating. So there was a conference, and I thought I might present our conference. And at a conference, and I went, Anyway, they are doing incredible things. So lucky I didn't put my name forth at the conference, because it would have been shot down, not by the IRA. It was in Dublin. But so my family are from Dublin, which is on the east coast, down low. And fortunately, when I looked at data and everything, there's an amazing nurse over there called Janice, who has been doing incredible things for many years in terms of cancer care in Ireland. But she's actually up in Donegal, which is up in the top left-hand corner, in a place called Letterkenny, where she's worked for many years. My dad and I went on a road trip. I'd been in contact with Janice to see how she was doing, what was happening. She had set up a pilot in Ireland only recently that was accelerated because of COVID and the need for them to actually provide safer care. So in Ireland, in Letterkenny anyway, they were already doing an oral clinic, but it was as an inpatient. They did it in their CDU, just as a normal, you know, they had an allocated nurse, but the patients were at higher risk of going into the CDU during COVID. So it necessitated what she had planned. It just accelerated the process. So she now runs a clinic, an oral anti-cancer care clinic, very similar, but in a community hub, which is close to the hospital. She sees many patients. So she's actually got her PhD. She's an incredibly intelligent lady, and she works in partnership with another clinical nurse specialist, and they've done lots of research and presented lots of conferences. They've had incredible outcomes. So I was lucky enough to go to the hospital for the day and visit the unit and go through all of Janice's protocols and policies and paperwork. They're paper-based still, so a little different. And then I got to spend the day in a clinic with her and with her patients, who were so incredibly generous with their commentary and kindness. So it was a fabulous experience. There's a lot of similarities between Ireland and Australia. They also do cancer hubs, so they have cancer care centres just like LRH, and then they have multiple hubs or spokes on the outset. And the thing that was incredibly obvious, even though they're up in the north, and because the language, the patients were really hard for me to understand, just because. But likewise, they had trouble understanding me for some reason. But cancer is cancer. It's the same wherever you are. It's the same in Ireland as it is here. But they did the difference over there. In 2016, they actually had some political reform, and it was called the Sláinte reform. And they now still have a shared political consensus that political parties won't argue over what's the right thing in health. And their health system, like everywhere else after COVID, is broken, but they're actually making some groundings because things don't get changed consistently depending on the political party. So they've got a 10-year implementation project, and they're actually doing great things. The place where I went, Donegal, has got the land mass only 10% of what we do. But they have a very similar population to us. And I've talked about those. They developed the clinic in 2020, just basically as COVID was, starting out. And in September, they started their first clinic. And it's continuing now. It hasn't changed. The model has manipulated a little bit. They're still funded. They're actually self-funding. They don't rely on the hospital. They're linked with the hospital still, but they don't actually require any additional funding. And their patients absolutely love them. They do in person and remote, but most of the people there preferred face to face. That's just the nature of the people there. They love a chat. So it was an incredible experience, and Janice has remained in contact ever since, asking how the project is going and what we're up to. And I think those sort of relationships, there's just not a price you can pay for them, because I've got so much to learn from her, and I hope one day she'll come and see us here. Just wanted to give some gratitude and thanks. Thanks for the opportunity. You know how passionate I am about caring and showing some kindness, and this is giving me a fabulous opportunity to do all of those things. So thank you to GRICS. Thank you to Letterkenny for letting me in. There was a little bit of a process, but we got there. That's the beautiful Janice. And then her counterpart, Mary Grace Kelly, both incredible women just making great changes. The GRICS Consumer Representative Group have been so incredibly engaging, and I am very grateful for them and all of the feedback they give me. They don't think it's making a difference, but it is, and I can't thank them enough. Ali, thank you for tolerating me. We didn't even know each other before we started this project. And yeah, now we probably know each other better than we'd like to. So I'm sorry, Ali, but I thank you so very much. And the same to Michael, my extended thanks for you tolerating my lack of everything. Emily, Griffin, Louise and Lara are all partnering with us as well in terms of the research from Monash Uni. Our beautiful Holly, that most people know as our med-onc, is forever, you know, flying the flag for me, and Tim, our pharmacist. So thank you so very much, and we're open for questions. Just please be kind to me.
No, thank you very much. That was really, really great, and it's really highlighting the issue, the fact that the oral anti-cancer use is increasing, and it's going to be a problem that we need to address, because I think that the increasing use plus the toxicity, multiple pharmacies that's been dispensed out of, and patient education and toxicity, and it's going to put more and more pressure on the health system as well. So we need to really look at our alternative models. So it's really a great presentation, and putting the scene for some important work for you to do, and then probably going forward around in the region and even in the state. I can see that really it's a lot of benefits. So I think, so have you started the clinic yet, and how many sort of patients have you seen? Sort of just an idea about.
We're only just starting now, and we've got at the minute four active.
Okay.
Yeah, it's a challenging space because Warragul is so small. It's been a benefit starting with low numbers because it gives me time. And the patients have been very lovely. So yeah, there's already, you know, I'm already getting positive feedback in just such a brief time. So it's been good. Yeah.
No, that's great. Yep.
I was just going to ask, Nate, as far as the clinic goes, if you get someone who doesn't consent to being in the study, do you exclude them from the education and all that sort of stuff as well, or do you still have them on board but not include them in the data?
They're not, no, essentially they're not. So to consent, they need to be, they will be provided with all of that. But those patients are still getting the care that they would be if any different. So they're still getting their education as it stands from Holly, or when it's dispensed with the pharmacist. And that's highlighting the issues that they can get. They don't have to get their drugs dispensed at a hospital. It can be dispensed wherever they like. So the education varies. And yes, there's EverQ modules for pharmacists. And it would be interesting to actually get that data on how many pharmacists are doing those modules in terms of dispensing. But in terms of the pilot, no, we don't see them anymore. I'm not that awful that I say, don't ring me, because I absolutely say, keep this number in your phone, and if I can help you, please ring me. That's just not in my nature. No, they're not. No, because a part of this whole pilot is to see what happens with patients that do have the pilot. And we're not going to look at those patients that don't get it, because essentially we kind of already know what happens with those patients. Their adherence is lower. Their side effects are you know, there's more presentations to ED. We're trying to stop all of those things. Yeah. Yeah. Yes.
Yep.
The
pharmacy. So who, like, was there a limit to like one pharmacy that you could use or pharmacists?
As part of the pilot, as part of the pilot, we're actually asking the patients to be dispensed from our pharmacy so that we can, and I think here at LRH, so it's different at every, but there is a degree of consistency that they're recommended. LRH, if they get prescribed something here, they have to get it dispensed, or they don't have to, but they're strongly advised because they provide some education here. Same happens at Sale. The pharmacist at Sale, Sam, provides an incredible service. He actually does monitor the patients and monitors bloods and everything, but he's incredibly unique for what's happening in the space. So it's different everywhere. So for the minute, we're asking them to be dispensed at the hospital, so they receive the standard of education that's provided there, so that we can look at is the pharmacist.
Yeah, I think it's really important to keep this consistent, because I think that's one of the main issues. I mean, I have sort of had sort of instances, for example, when I prescribe something, the patients would take it instead of, like, let's say, once a day, but 3-4 times a day, because it's 4 tablets. So really, it's not unusual. And I mean, one, because the pharmacy itself, they are not used to prescribing so many variations, and that's whether it's, you know, for prostate cancer, breast cancer, or whatever it is. So it's and the regimes are different, and so, you know, we just have to sort of put the guardrails around it, because I think that the community pharmacy sort of the structures and process that were there, it's probably not, you know, ready for the, you know, the new wave of cancer treatment, because these are complex cancer treatment. They're not just like your normal, you know, hypertension medication that everyone prescribes. So it's, I think really we need to really move a dial up sort of in service provision as well. And I think, you know, the obviously I'm not sure whether you're looking at it, but are you looking at the sustainability and the funding model? Because I think this is, again, the main issue in this way, because as you showed, that there are so many guidelines in Australia, but no guidelines to implement and monitor it. And that's the sort of the funding, which is, you know, you can have as many guidelines as possible, but, you know, if you don't implement and monitor it, it's not going to happen for another 10 years. So I think we can't keep just doing guidelines but not implementing. And hopefully the new cancer plan just comes up with some sort of a direction or process for that.
Well, initially it was just for the 12 months. Ethics did take us an incredibly long time. So we're extending into next year. Yeah, so we haven't really discussed how far we'll go. We'll see how we go with enrolments and whether we have to twist and try and get some more enrolments from other services to see. But yeah. And we are looking at the cost, because really it all comes down to resourcing. You know, pharmacies are under-resourced, the units are under-resourced. You know, it comes down to the mighty dollar, sadly, but that doesn't mean that we shouldn't still try. Yeah.
So just with that in mind, you're hoping to roll a pilot out to
beyond, yeah, in the next, like, we're looking at a partnership, and it's not that we're excluding LRH, but LRH do have a framework of a process in place. We're probably looking at a Bairnsdale partnership at some point, because the patients are certainly more rural, more spread out. You know, how we've got one of the nurses there is very keen to partner with us. So we'll roll out and see the tweaking, what we need to do, and see, yeah, what we do. But absolutely, we're looking at a regional, you know, process. Yeah, yeah, absolutely. It's yeah.
Just picking up on what Monash said, so obviously lots of different cancers, lots of different therapy, lots of different timing of therapy, rest periods, twice daily medication, once a day. How are you looking at the process of compliance and documenting that?
Yeah.
Those different cancers?
Yeah, so that's something that's a little challenging, and we're going to probably put in place a calendar format, because that seems to be the thing that most people can relate to most, because it's simple, but it's sustainable. You know, it's something, and we can put multiple things on a calendar, including blood tests, including appointments, including, you know, timing of drugs. You know, I've got one of the first enrolments was a lady who'd been taking a drug. So when it's not just people that are starting, it's existing patients as well. So the existing patient, she's been taking it with her brekkie. Now it should be taken 2 hours after breakfast and an hour before. I'm not about to change though, because she's getting good, you know, her results, it's sustaining her disease. And who am I to come in and say, oh, you got to change it? Because I'm not going to win, you know. I want her to trust me. She's doing fine. And if we can manage her symptoms aren't related to her timing. You know, she's got other things. So it's just those interesting things that we can't be set in stone. But absolutely we are monitoring adherence, and that's one of the things that we're looking at, and not just adherence into have you taken it every day? Have you taken it at the right time? Have you stopped it? They are so incredibly complex. I would not be a good patient in this term. Yeah.
Any other questions or any
And
questions
anything
online?
Michael's online, if there was.
So Michael, yeah, that was really, really nice data. So that's coming from the PBS sort of data set, is it?
Yeah, that's PBS. PBS data from Services Australia, their aggregate data. But I'm also looking into accessing data broken down by further subnational areas. So broken down by like SA2 and remoteness areas. So we can get data, for example, for Shire, and at those levels, hopefully, I've put in a data request to Services Australia to access those data. So fingers crossed.
Have you got any thoughts on why the hormonal treatments went down in around that time? Because I couldn't really sort of think about why that happened from a clinical point of view, or is it some coding something, or something came off sort of a authority, or is that what? Why?
Yeah, we've been pondering that one ourselves, and I'd welcome your thoughts. We were thinking that it could be to do with changes over time in the indications for individual agents. So the indications can for particular cancers for a particular agent can expand or decrease, or there could be changes in co-prescribing in regimens that are recommended. So it may be something to do with that, or as you've said, Mahesh, it might be something else.
Yeah, no, it's fascinating, because I think couldn't really sort of see, because you would expect it to remain the same or increase, and in breast cancer and hormonal agents are in breast cancer and prostate, so that's sort of the two main drivers of it. So I couldn't really see that. So any other questions, anyone?
The studies and that sort of thing. Did you look at that before you started, or as you went along? Was it a surprise that there was such lack of information in the area that's been researched?
So we did look at it later, because our intention really was to start with a pilot and a feasibility study to do something small and get it right. So we weren't jumping into the clinical trial, as most people think is the best thing to do, but it's actually the thing you need to do at the end once you've got everything set in place. So I'm not surprised by that, because there's a lot of people doing projects around that, which is fine. That's great. I guess from a research and an evidence point of view, you want to do something a bit more robust. So which is why we're trying to start small and get things right as we go along. Hopefully one day get to that clinical trial we would like to move this into. Yeah. Thanks.
So thank you. Yeah.
Obviously, cancer treatment over the last 20 years has changed significantly. I've personally seen a lot of research and change over the last few years into oral agents. Are you of the same opinion that oral cytotoxic chemotherapeutics will be driven more into an oral arena?
Yeah, I think it's going to be, there's going to be more and more coming in, sort of, the PARP inhibitors coming in for ovarian cancer, patients on it for 3-4 years. Now CDK4/6 inhibitors in breast cancer, 3-4 years. So it's going to put this kind of clinic in the forefront. I know certainly in the UK NHS setting, that's nurse practitioners practitioners are running some of the olaparib clinics, and they're not really seeing the medical oncologists sort of and like chemoradiotherapy. So there's really a lot of expansion, and then these kind of models will need to happen, because I don't think the system can cope with the increasing in the treatment paradigms, new treatments and things like that. So it is here to stay, and it's just about how we modify the processes to sort of to make account of those changes and still deliver safe and efficient care. So I think looks like that's about it, and thank you very much everyone for joining in the auditorium and online, and thank you very much for Ellie, Michael and Sinead for that wonderful really presentation on a very important topic that's really important for the patients, for the community, and probably from a statewide point of view it's very important as well, because I think this is probably really a pilot for that's really going to sort of change how how we do things, certainly locally and maybe even in a bigger picture. So thank you very much for joining, and I will close the forum. Thank you.